Of blood pumped out of each ventricle per minute is called as cardiac output, and the normal value is around 5 liters per minute in normal adult. Cardiac output can be written as stroke volume into heart rate, where stroke volume is the amount of blood pumped out of each ventricle per beat, which is around 70 ml, and heart rate is defined as the number of beats per minute, that is normally it is around 75 beats per minute. And cardiac index is the cardiac output in liter per minute per meter square of body surface area, and normally it is around 3.2 liters per minute per meter square area. There can be variation in the cardiac output. Physiologically, increase in the cardiac output can be seen in exercise, anxiety, excitement, and pregnancy, and the decrease in cardiac output is seen in standing from lying down position and in females. Some of the pathological causes for increase in cardiac output are anemia, hyperthyroidism, hypoxia, fever, and beriberi. And decrease in the cardiac output are seen in hypothyroidism, myocardial infarction, valvular heart disease, hemorrhage, and cardiovascular shock. Coming to regulation of cardiac output. Cardiac output is determined by stroke volume and heart rate. So hence it can be given as stroke volume into heart rate, as we learned. Hence all the factors that regulate stroke volume and heart rate regulate the cardiac output. Stroke volume depends on three important factors, that is preload, afterload, and myocardial contractility. Regulation of stroke volume. It is by two important regulatory mechanisms, that is heterometric and homometric regulation. Heterometric regulation, factors that change the length of the cardiac muscle fiber, and this is affected by factors which act within the heart. So this is called as intrinsic regulation. This is based on Frank-Starling's law. Thus it is independent of chemical or nervous factors. As mentioned earlier, the force of contraction is dependent on preloading and afterloading. Preload. In the ventricle, the preload is the amount of blood present in it before it has started contracting. That is, it depends on end-diastolic volume. So within the physiological limit, more the end-diastolic volume, more will be the cardiac output. The factors affecting end-diastolic volume are the venous return. When venous return increases, end-diastolic volume increases. Venous return in turn depends on the blood volume. When blood volume increases, the venous return increases and diastolic volume increases. So stroke volume and cardiac output. It also depends on venous tone. When there is an increase in the venous tone, leads to decreased pooling of blood in the periphery, that increases the venous return, and hence EDV increases. It also depends on skeletal muscle pump. Veins are surrounded by skeletal muscles, and when they contract, they reduce the capacity of venous reservoir by squeezing the veins and diverting the blood to the heart. So end-diastolic volume increases, so cardiac output increases. Intrathoracic pressure. An increase in normal negative intrathoracic pressure increases the pressure gradient along which the blood flows to the heart. So more blood is sucked into the thorax, venous return increases, and it is important during inspiration, as here intrapleural pressure falls. Posture of the body. Venous return is maximum in lying down posture. During standing, there is a venous pooling which in turn decreases the venous return. Atrial contraction. When atria contracts more effectively, the end-diastolic volume increases. Intrapericardial pressure. As intrapericardial pressure increases, there is a limit for ventricle to expand, and so filling is reduced. Depends on ventricle compliance as well. If the expansibility is less, the end-diastolic volume reduces. Afterload. For a left ventricle, afterload is the blood pressure in the aorta. When afterload is more, ventricles have to work more. It is called as aortic impedance or aortic resistance. When afterload increases, cardiac output automatically decreases. Coming to homometric regulation, by changing the factors that change the contractility of myocardium, and it is independent of cardiac muscle fiber length. It is regulated by factors which operate outside the heart like neural and chemical factors. So it is also called as extrinsic regulation. Neural regulation. When there is a sympathetic stimulation, there is an increase in the force of contraction, which occurs via beta 1 adrenergic receptors, which activates adenyl cyclase that increases the cyclic AMP, which increases intracellular calcium levels, and that is going to increase the force of contraction. Parasympathetic stimulation produces negative effect. The chemical substances like xanthine like substances like caffeine, theophylline inhibits the breakdown of cyclic AMP, so they help in more accumulation of the calcium inside the cell. Glucagon increases cyclic AMP levels and hence the calcium levels. Thyroid hormone also increases cyclic AMP. Drugs like barbiturates, quinidine increases the force of contraction. Hypoxia, hypercapnia, acidosis are the other chemical factors which decrease the force